I'd like to start by thanking the OCRA for inviting me to speak today. I'm Alison Schram. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center with a focus on early drug development and gynecologic cancers. Today, I'll be talking about tumor agnostic therapies, a tumor agnostic approach to cancer care. These are my disclosures. So traditional cancer treatments primarily consist of surgery, radiation therapy, and chemotherapy. And these can be used individually or in combinations. Generally, in the setting of curable disease, they are used in combinations or individually, but chemotherapy alone is often given for advanced disease. Precision oncology is a personalized approach to cancer care that uses a tumor's specific genetic and molecular characteristics to guide treatment decisions. The aims are to maximize the effectiveness of therapy and minimize side effects by selecting therapies that preferentially target the cancer and spare normal cells. This involves testing tumors for specific molecular alterations to identify biomarkers that can predict which treatments, like targeted drugs or immunotherapies, are likely to benefit an individual patient. So to get to the basics about what a molecular biomarker is, a molecular biomarker is a molecule produced by the tumor or as a response to the tumor that can help with diagnosis and provide predictive and/or prognostic information to guide patient care. And this can be identified on DNA, RNA, or protein. To remind everyone, DNA is the blueprints of the cell, and DNA can be transcribed, something we call transcription, to make RNA molecules, which are single-stranded molecules that then undergo something called translation to become a protein. These are all molecules within a cell, and the order of really the blueprints going through to execution are DNA to RNA to protein. Proteins carry out functions of the cell. So a genetic mutation typically occurs at the DNA level and results in abnormal protein, which can lead to a gain of function, a loss of function, or abnormal function of the protein. So the protein, which is a molecule that carries out an activity in the cell, can be too active, it can be underactive, or it could function differently than it's supposed to. This can prevent protein from being made as well. So a mutation can also just prevent the production of the protein altogether. And any one of these alterations can lead to tumor growth and survival, depending on the specific protein involved. So here you see a schematic showing a mutation in the DNA leads to an abnormal RNA, which leads to abnormal protein. Amplification and/or overexpression is a result of typically of too many copies of a gene. So amplification is that there are too many copies of a gene, that this is something that can abnormally happen in cancer, and that results in increased RNA being made and consequently too much protein. And there's also other ways to get too much RNA that aren't exactly amplification, but cause what we call overexpression, so too much RNA being made in the absence of amplification in some cases. And that can be because there's too much transcription of a gene, for example, that has not been amplified. So even though there might be only two standard copies, there can be more transcription, which again is how DNA goes to RNA, and that can lead to too much protein. Too much protein, and if it's a protein that's important for telling cells grow, divide, and survive, can lead to cancer. Gene deletions. So this is the opposite of gene amplification, a deletion of a gene that results in less RNA and consequently less protein. And there are also other ways to get too little RNA, similar to what we just discussed, but the opposite. So decreased transcription of a gene, for example, can lead to too little protein. And this can also lead to tumor growth and survival. And again, what these mutations, deletions, amplifications do depends on what the function is of the DNA or the protein that is being altered. Last but not least, gene fusions. So some of you may have heard of gene fusions. This occurs when two previously independent genes combine to form a single hybrid gene, and the resulting fusion gene can produce what we call a fusion protein with altered or new properties. This can lead to tumor growth and survival. So in ovarian cancer, there are several different molecular biomarkers, and the list of potential biomarkers continues to expand. Here I'm showing just some of the more well-validated and well-known biomarkers, including HER2 overexpression, which I'll talk about in just a minute. This can be a consequence of HER2 amplification, as I mentioned, or HER2 overexpression for other reasons like transcription, excess, folate receptor 1 overexpression, what we call FOLR1 positivity. And there's an FDA approved drug for ovarian cancer that targets this called mirvetuximab. KRAS mutations can occur in ovarian cancer, although it's relatively rare, but there are new drugs targeting KRAS that may become more mainstream in ovarian cancer as we continue to study them in clinical trials. BRCA mutations, BRCA1 or 2 mutations, which many of you may have heard of, which are a biomarker in the DNA that can cause an abnormal BRCA protein, and that has implications for the treatment of ovarian cancer. And then P53 mutation. So P53 is a tumor suppressor that is altered in almost all high-grade serous ovarian cancers. And we are just learning, which I'll talk about a little bit more later in this talk, how to target that specific alteration. So how do we identify a potential biomarker? There are several different ways that you can identify a biomarker. One is a tumor biopsy. So you take a sample of the tissue from the tumor. This is generally a procedure that is done. And you can get information about the pathology. So what kind of cancer is it? What does it look like under the microscope? You can also do testing using this little symbol on the bottom middle here, which is a sequencer. You can do DNA or an RNA sequencing to look at what is the DNA transcript, what is the RNA transcript, are there specific mutations that we can identify? And you can look at the protein in the cancer as well. So you can look under the microscope and actually stain for the amount of different proteins, like the folate receptor, for example. There are different genomic tests available, from single mutation tests that test a very specific thing to these large panels that test 500, sometimes 800 cancer-related genes, and even whole genome sequencing, which sequences the entire genome. In addition to tumor biopsies, there's something called liquid biopsies that are becoming more commonly used. This is a blood test that is done that looks for circulating DNA in your blood that has been shed from the cancer. And that can give us information about mutations as well, and less information about RNA and protein now, but we are trying to develop circulating RNA tests as well. And then there's blood samples for normal DNA. So this actually can be very informative for a few reasons. One is that it can give information about inherited mutations, so what we call germline mutations. And an example of that would be a BRCA1 or 2 mutation. If you have inherited one abnormal copy from a family member, that can increase the risk of developing ovarian cancer. And it's important to know that because that may have implications for treatment and implications for your family. And that can be detected from a normal blood sample. The normal blood samples are also very useful because we can use them to compare to the tumor biopsy DNA and the liquid biopsy DNA to say what is different about the cancer DNA compared to what you were born with. And that can help give us information about what drives the cancer, what is different that is perhaps causing the cells to grow and divide in an uncontrollable way, and therefore might be worthwhile to target therapeutically. So how do we identify a potential biomarker? There are a couple of different ways that you can clinically look and see whether a patient has a biomarker. On the left, you see an example of a genomic report from one of the commercial companies that you can send your tissue to. And this gives a lot of information. A lot of these reports are slightly different, but all have a lot of information that can be useful to guide treatment. So the high impact results here are shown at the top, and those include some of the mutations that have been found that are relevant for the particular tumor type. Here you also see some protein level information from the immunohistochemistry. And there's often a list of additional results that may be important because although there may not be a specific FDA approved drug for the additional results, there may be clinical trials that are available that are studying therapies targeting those alterations. And that is often listed further down in the report as well. There can be on the right, you see there's these levels of information, these biomarker levels. This is a bit nuanced, but a level 1 biomarker is saying there is an FDA approved drug that targets this, and therefore this is standard of care to use this biomarker for treatment decisions. And then when you get down to level two and level three, there is lesser degrees of what we call actionability. So the biomarker may predict for potential response to a treatment, but that's still being therapeutically studied on a clinical trial. And so it is useful to look and see what the mutations are and what the different levels of evidence are for targeting those. On the right, you see an example of some public knowledge bases. This is just a long list of public knowledge bases that you can find online that you can type the mutation in and see, what does this mean? Are there treatments that target this? Is there some kind of therapeutic implication for the results of my genetic report? So that is also available. But kind of taking a step back in terms of just the way that we approach cancer care in general. So the traditional cancer treatment paradigm has been that cancer is typically treated based on the site of origin. Breast cancer, colon cancer, lung cancer, for example, you take the place where the cancer originated from, and treatments are generally targeted to that specific site. And you can see here just a small snippet from the NCCN guidelines, which are guidelines that oncologists use to help guide treatment decisions. And the guidelines are separated into diseases, which really correspond to how we think about these, or at least historically have thought about these diseases. We treat things based on the tumor site of origin. But there is this evolving paradigm of precision oncology. And so historically, anti-cancer therapies were studied in disease-specific clinical trials, which makes sense because that's how we were thinking about and treating cancers. So for example, a clinical trial would test a new drug in breast cancer or in lung cancer or in colon cancer. And this includes studies of molecularly targeted treatments. So if you want to test a treatment that's targeting the folate receptor, for example, you might study it in ovarian cancer specifically. But recently, there's been increasing molecular profiling across cancer types, and we've come to realize that there are some shared molecular alterations that are prevalent not just in one or two or three disease types, but actually can be found across different cancer types. And this has really changed the way that we think about drug development. So we've started to use, with increasing frequency, basket trials. Basket trials are a methodology of clinical trials that evaluate molecularly targeted therapy across cancer types simultaneously. These studies include patients regardless of their disease type if the cancer contains a shared molecular alteration. So you can see in the figure here, there are patients with melanoma, prostate cancer, breast cancer, and lung cancer. But in each of the examples, one or two patients have a specific molecular alteration denoted by the circle. And the basket trial studies patients with that specific molecular alteration regardless of their cancer type. So rather than grouping them by disease, we're now grouping them by molecular alterations. And this is really a shift away from, as I said, the traditional approach to studying cancer, but also a shift away from the traditional way of thinking about cancer. Rather than thinking about cancer as just the disease site of origin, we are thinking about cancers that have similar biology or similar drivers as potentially more of a unit. And so tumor agnostic or tumor tissue agnostic therapies are therapies that are effective in patients that are across different tumor types, generally if they have a shared molecular alteration, something called a biomarker. Tumor agnostic biomarkers are molecular alterations that, as I said, confer sensitivity to a therapy irrespective of cancer type. So if you have a targeted therapy targeting a specific molecular alteration, it may not matter whether the cancer is breast cancer or cholangiocarcinoma or lung cancer, as long as they have that specific alteration. And there have been now several tumor agnostic therapies FDA approved to use across different cancer types. So to go to the basics here, in terms of a precision oncology how-to, the first step really is identifying a biomarker. Researchers identify a specific molecular alteration or biomarker that drives growth or is prevalent in a particular cancer. They develop or across cancers, they develop a targeted drug. So a drug is either developed or repurposed to target or inhibit the specific molecular pathway or protein affected by the biomarker. Clinical trials are then conducted in a variety of different cancer types who share the same molecular biomarker. And if the drug shows significant effectiveness across diverse cancer types, it could potentially be approved by regulatory authorities to treat patients with a specific molecular alteration, regardless of where the cancer is coming from. So this is a bit technical, but talking about biomarker validation, how do we determine that a specific molecular alteration is worth targeting? And it's really an iterative process that often uses bioinformatic data, meaning computer data from large databases of patients with genetic data included, in silico, meaning in computer simulation, in vitro, meaning in the lab in a dish, in vivo, meaning testing in animal models, and then clinical trial data. So we take this totality of data together and we learn from it. It usually includes testing multiple disease sites, like basket trials. Basket trial that includes multiple sites together or multiple disease-specific sites. So many different trials that are each in a specific disease, or a combination of the two. So you may have done a lung cancer study and a breast cancer study that showed that something was a good biomarker and then said, okay, well, I'm going to then look further and done a basket trial. And you take the totality of that evidence and say, actually, it doesn't really matter where the cancer came from as long as it has this genetic marker. But the ability to target a molecule depends on the available therapies. So this is constantly changing. The potency, meaning how strong a medicine is, the therapeutic index, meaning how effective it is compared to the side effects and how much you're able to get and patients can tolerate. And then, of course, the mechanism of action. There are different mechanisms of action of different drugs, and whether or not a drug effectively works in a biomarker depends on whether it makes sense biologically. So you see this kind of pyramid on the left of biomarker validation, starting with really the most basic identification of a potential marker on the computer through to clinical trials. And then on the right, you see a schematic really showing that this is an iterative process. Patients get a biopsy, they have their tumor molecularly characterized, they get a report, they're matched to a clinical trial. And then on the other side, you have this biomarker identification and validation, and patients go to clinical trials, but then we get the results of clinical trials and we learn from that. Maybe there were certain there were certain mutations that seemed to respond on the trial, but not others. And then you develop another trial, or you iterate the same trial to specifically include those patients. So we're constantly, learning in a feed-forward way how to validate these biomarkers and develop the best therapies. So these are the current tumor agnostic biomarkers that have been approved to date. There have actually been several of them, as you can see. The first was pembrolizumab back in May of 2017. This is an immunotherapy, and it works by causing your immune system to actually see the cancer in a better way. It unveils the cancer to the immune system and allows your own immune system to attack the cancer. This was approved for patients that have what we call mismatch repair deficiency. And that means that their cancer is not able to repair DNA effectively, and therefore they get a lot of abnormal proteins, which make the cells appear foreign to the immune system and therefore make it a good target for an immunotherapy that is dependent on the immune system being really revved up. Also, the next therapy was larotrectinib that was approved. That was in 2018, followed by entrectinib. These are both small molecules that inhibit a rare genetic fusion in NTRK. And these are found across different cancer types at rare frequencies. And the results of really stunning clinical trials showed that NTRK fusions were exquisitely sensitive to these small molecules, regardless of where the cancer was coming from. In 2020, pembrolizumab was again FDA approved in a second tumor agnostic approval for patients with high tumor mutational burden. And that's really a similar concept to the mismatch repair deficiency back in 2017, but a little bit different. Patients that have high tumor mutational burden have a lot of genetic mutations. And again, they have a lot of abnormal proteins. And that's just by really looking at the DNA. Do they have a lot of mutations? We predict that they have a lot of abnormal proteins. Therefore, the immune system would see the cancer more readily. And immunotherapy makes sense in that population. Dostarlimab, similar to pembrolizumab, was also FDA approved in a tumor agnostic indication. And then in June of 2022, we actually had kind of a new type of therapy, a combination of a BRAF inhibitor and a MEK inhibitor, dabrafenib and trametinib, approved for patients with BRAF V600E mutations. These can be seen across cancers, often in melanoma or lung cancer, but they can also be seen in low-grade serous ovarian cancer. And so this is an interesting one for ovarian cancer patients to note that BRAF V600E mutations, although rare, can be seen particularly in low-grade serous ovarian cancer. And this treatment was approved regardless of the cancer origin. So again, if you have ovarian cancer, it may be effective and it's an FDA-approved drug. Jumping ahead, selpercatinib was approved for RET fusions, another rare genetic fusion. Trastuzumab deruxtecan, also known as Enhertu for HER2-positive cancer, and I'll go into that a bit more in detail. And then repotrectinib, another NTRK small molecule inhibitor. So this really shows that over the last decade or so, there has been a true shift in the paradigm of precision oncology and of oncology generally towards looking at diseases in terms of their molecular makeup and not only their site of origin. So, what is the evidence that we have for these tumor agnostic biomarkers? These slides are a bit technical, but on the left, you see what we call the overall response rate. So the rate of patients who have significant tumor shrinkage of 30% or more on subsequent scans, which we interpret as patients really benefiting. So the percentage of patients that seem to really benefit from these therapies, and the overall response rate is really anywhere from around 30% for pembrolizumab and TMB high to almost over 70% in larotrectinib. And then on the right, you see, what was the evidence that led up to the tumor agnostic approval? Was it just one big clinical trial that enrolled patients regardless of their tumor type, like dostarlimab, for example, on the top? You see this one big clinical trial. Or were there many trials along the way in specific different diseases before ultimately it was studied in a more broad way and got an approval in a tumor agnostic way? So dabrafenib, trametinib is an example of that. On the bottom, you see there have been many clinical trials and disease-specific indications. And then we said, well, maybe this doesn't just work in those one or two or three indications, but can be used across different tumor types. So here you see the frequency of these tumor agnostic biomarkers in cancer, and these are the validated FDA-approved indications. Looking at gynecologic cancers on the top left, which is, of course, of interest to us, you see in patients with mismatch repair deficiency or MSI high, it's about 14%. That is typically endometrial cancers. TMB high, about 17%. Similarly, that's more often endometrial cancers. The BRAF V600E, as I mentioned, that can be seen in low-grade serous ovarian cancer, occasionally in other gynecologic cancers as well. And for the others, RET and NTRK, more rare. On the right, you see HER2. This is broken out because it was a later FDA approval, and I felt it deserved its own figure here. And you see that in ovarian cancer, there is a non-trivial frequency of HER2 positivity. So what we call HER2 3+, which is basically the pathologist looks under the microscope and says there's 0, 1, 2, and 3, 3 being the most. There's the most HER2 that we can see and in the cancer, which is something that we would want to target with a treatment. And so in ovarian cancer, you do see HER2 positivity. Not always, but low frequency, but still worthwhile to look. So there are many approaches to targeting a biomarker, and a lot of the drugs that I just mentioned work in very different ways. It's interesting to note the different drugs that have been approved for tumor agnostic indications so far, and the ability to target something, of course, depends on the types of drugs that are available. So the top here, you see a monoclonal antibody. That is an antibody like your body might produce in response to an infection, and pembrolizumab and dostarlimab, these immunotherapies, are what we call naked antibodies. Antibody drug conjugates are next. An example of this is trastuzumab deruxtecan, also known as Enhertu. It is an antibody that's very similar to a monoclonal antibody. However, on it, there have been very strong chemotherapies attached so that the antibody localizes the chemotherapy to the cancer, and then it is internalized and the chemotherapy is released specifically in the cancer cells. So it allows a very strong chemotherapy that would not otherwise be tolerated if just given IV to get specifically to the cancer and exert a strong effect in that way. And then there's small molecules. So you see the long list of the small molecules that have tumor agnostic indications here. Those are drugs that basically go into a protein and they block the action from taking place. So there may be something that turns the protein on, and the small molecule slips in there and doesn't let that thing attach, so that you don't get the on button, so to speak, and these proteins are turned off in consequence, causing the growth stimulus to subside and leading to tumor shrinkage. So HER2 overexpression, I'll just talk a bit more about this one because, as I said, it is seen in gynecologic cancers, ovarian cancer, but more often, honestly, in ovarian, endometrial cancer, specifically uterine serous cancers, have a higher rate of HER2 overexpression. And trastuzumab deruxtecan is, as I said, it's an antibody that has attached to it chemotherapy, and it attaches, it's internalized, and then releases the chemotherapy into the cell. Trastuzumab deruxtecan was originally studied in breast cancer and gastric cancer, two diseases where HER2 positivity is common, HER2 overexpression is common. And what we're looking at here are the results of some of the pivotal clinical trials. These are waterfall plots. The way to think about this is on the x-axis, you have individual patients. So each bar is an individual patient. On the y-axis is the best percentage change in their tumor volume. We measure it in a specific way, but you're really looking at the sum of the diameters of their visible cancer. And if you have, for example, 100% tumor shrinkage, the cancer visibly disappears, you would see negative 100% here. If you see the cancer shrinks by 30%, you would see 30% tumor shrinkage. And that dotted line represents 30%. We put it there because, as I mentioned, that's part of the definition for overall response rate, which is clinical trial definition. But the overall kind of gestalt of this is you want to see a waterfall with the bars going down, and you don't want to see a geyser with the bars going up, meaning you want cancer to shrink in patients. And you see here what is really one of the best waterfall plots that we've seen, which is that almost all of the patients had tumor shrinkage on these clinical trials in breast cancer and in gastric cancer with really incredible results. So then this drug was studied more broadly in other tumor types, and you see here the non-breast, non-gastric cancer patients and their waterfall plots. I've highlighted ovarian cancer here. The majority of patients with ovarian cancer had tumor shrinkage. In patients who had the highest level of HER2 protein expression, IHC 3+, as I mentioned, the overall response rate was 63.6%. Even patients that had lower levels, like the HER2 2+ had about 36.8% in terms of the overall response rate. But again, this means that it shrunk by 30% or more on 2 subsequent scans. So even additional patients are benefiting from this therapy that just don't meet those specific cutoffs. So this is really kind of incredible in terms of the number of diseases that are benefiting from this therapy. You see cervical, endometrial, ovarian, biliary tract, pancreatic, bladder, and it doesn't seem to really matter where the cancer is coming from as long as they have this specific molecular alteration. Here are the swimmer plots. This is another way of looking at how well a drug works. The y-axis is individual patients, so it's flipped compared to the other waterfall plot I had mentioned. And on the bottom, the x-axis is time. So each individual patient is showing how long were they on the treatment for. And you can see that patients were on this treatment. It wasn't just that their cancer shrunk, but they were on the treatment for a long time. Many were on for over a year. So that is giving a sense of the durability of the treatment. And so based on the totality of this evidence, trastuzumab deruxtecan was FDA approved to patients that have HER2 positive solid tumors, regardless of the cancer origin. And that was defined by immunohistochemistry of 3+. So again, you look under the microscope and you see that there's just a lot of HER2 on the cells. And in those patients, trastuzumab deruxtecan is now FDA approved, regardless of the tumor type, something we call a tumor agnostic approval. But over the last several years, in addition to the tumor agnostic approvals I've mentioned, we've also seen a rise in the number of molecular targets. More patients are getting molecular profiling. We're getting better at the technology of looking at the molecular targets. And some of these may be emerging tumor agnostic biomarkers. So I'd like to call out just a few. One here is a p53Y220C mutation. I previously gave a talk at OCRA discussing this, so I won't go into much detail about it, but p53 is the most commonly mutated gene in cancer. p53Y220C is a very specific mutation in this gene, and we have now what we call p53 reactivators, which are small molecules that reactivate this protein that has developed loss of function from the mutation. And the reason that this is interesting for our audience here is because in ovarian cancer, this can be seen in it's about 3.6% of all ovarian cancers, but it goes up to more like 4 to 7% of high-grade serous ovarian cancers. And although that's not everyone, of course, we're starting to chip away at, the different targetable populations here and do better for patients, even if they're relatively rare populations. So this Y220C alteration, it can be seen across different diseases. It's an interesting potential tumor agnostic biomarker, but does seem to have a slightly increased prevalence in ovarian cancer. I'll talk a little bit more about NRG1 fusions. This is another emerging potential tumor agnostic biomarker that is, I think, very exciting. And so in terms of biology, neuregulin, also known as NRG1, is the ligand, or really the food that feeds HER3, which is a protein that sits on cancer cell surfaces. And this is important for cell survival, even in normal cells. But NRG1 fusions are these abnormal gene fusions that I mentioned earlier that cause the neuregulin to stay close to the cell, to be tethered to the cellular membrane, and lead to overactivation of this pathway. NRG1 fusions are found at very low frequency, but across different cancer types. They can be seen in many different cancer types. They are more common in otherwise driver negative lung cancer and pancreatic cancer, meaning there's not another genetic driver that we see, but it can be seen in ovarian cancer, although it's rare. Zenocutuzumab is a bispecific antibody that blocks this NRG1 fusion from signaling and causing cancer growth. And it was also optimized to allow the immune system to see cells that had this molecule bound to it. So there is an immunotherapy component as well. This is a waterfall plot showing zenocutuzumab activity in NRG1 positive cancer. This is across tumor types in what we call a basket trial. The overall response rate was 30%, but you see the majority of patients had tumor shrinkage. And I'm calling out here with the arrow an ovarian cancer patient, the one ovarian cancer patient who we enrolled on the clinical trial that had a response to therapy and benefited. This is the swimmer plot, again, showing the time on treatment, and the median time to a response was 1.8 months. The median duration of response was 11.1 months. And at 6 months, 77% of patients were still responding of those that had a response. So this is really showing that patients not only have tumor shrinkage, but this can be very durable. If you pull out the lung cancer and the pancreatic cancer groups, these were the groups that enrolled the most patients, and the response rates were clinically meaningful. The durability was clinically meaningful. And on the basis of this data, the FDA recently granted accelerated approval to zenocutuzumab for patients with pancreatic and lung cancer. But what does that mean for patients with ovarian cancer? NRG1 fusions are very rare, but could predict for benefit to zenocutuzumab. And as I mentioned, there was one patient with ovarian cancer enrolled to this clinical trial, and she did benefit. She had a response, and she clearly benefited from therapy. So, what does that mean for these other diseases that have this alteration, but not sufficient data to really get an FDA approval? So that brings me to some of the challenges in tumor agnostic drug development. There are several challenges. One of them is, of course, needing sufficient data to really say that this is worth targeting across different cancer types, which can be tricky, particularly in rare tumors and in rare biomarkers. We also need robust biomarkers, so identifying the specific molecular alteration that can effectively predict treatment response across diverse tumor types can be critical and is challenging. So there may be different potential biomarkers for a given therapy. We talked a bit about HER2 and how HER2 3+ on immunohistochemistry is a biomarker for in HER2 or trastuzumab deruxtecan. But what about HER2 2+? Or what about genetic mutations in HER2? There may be a few different potential biomarkers for trastuzumab deruxtecan, and it may work slightly less or more well, depending on the specific biomarker that you choose. Of course, there also needs to be effective drugs. So having a good biomarker is not enough. You need a drug that is tolerable and can really target the pathway and is able to be given clinically. So that is, of course, critical for pairing a drug with a biomarker. It also can be tricky in tissue agnostic drug development because oftentimes there's not a good comparison. Many of the tumor agnostic trials use single arm designs where they enroll patients on a study and give them all the therapy. There's not a control arm. And that can make it difficult to say, is the benefit statistically significant compared to standard of care therapy? One of the reasons it's often done that way is because the standard of care therapy is different. So the standard chemo for pancreatic cancer is different than the standard chemo for breast cancer and gastric cancer. And so if you want to include all of these different tumor types on a trial, it would be very challenging to randomize half of the patients to get different therapies and to really interpret that data, or it'd be unethical to randomize them to get the same therapies since we know that that same therapy doesn't work equally well in the different cancer types. Additionally, there can be primary tumor resistance. There are other mutations that can be found sometimes, or other molecular alterations within a tumor that may set the patient up to not respond well to the therapy. And the genomic context is different from patient to patient and from cancer type to cancer type. And we also do see that there are sometimes exceptions to the hypothesis. So a tumor agnostic therapy's effectiveness doesn't always hold true for all cancers with the target biomarker. So an example of that would be the BRAF V600E FDA approval for dabrafenib and trametinib. It was noted that colorectal cancers did not have the same degree of benefit. And so that tumor agnostic approval said, except for colorectal cancer. And there's a biologic underpinning for that. But it is important that we recognize that it's not quite black and white. And there may be differences that may depend in part on the tumor type. So that gets to these tumor biomarker types. Rather than being a dichotomous tumor agnostic or tumor specific biomarker, there really is a variable degree of efficacy across tumor types. And this can be influenced by genomic, proteomic, also known as protein or epigenetic modifiers. That is a different way of modifying the RNA level. And so perhaps it's not just tumor agnostic, which targets a driver alteration irrespective of the tumor type, or tumor restricted, which is tumor specific and only targets a driver in a tumor specific context. But there may also be these tumor modulated biomarkers that are somewhere in the middle, where the therapeutic effect on a target driver alteration is modulated by the tumor specific biology. An example of this is BRCA1 and 2 mutations, which confer sensitivity to PARP inhibitors, but more so in specific diseases like ovarian cancer, for example, pancreatic, prostate, and breast cancer, as compared to other diseases. So that makes it really tricky from a regulatory perspective. How do we know when to approve a drug in a tumor agnostic way versus just different disease-specific FDA approvals? And we looked back to see at all of the tumor agnostic approvals, were there some similarities in terms of what the FDA thought and what clinicians thought was necessary in order to have the bare minimum for a tumor agnostic approval. And this is very jargony, but basically there needs to be a good preclinical rationale. There needs to be a good mechanism as to why this drug with this biomarker would make sense. And there needs to be clinical trials that show that there are several different many different disease types enrolled. There are many different patients enrolled in each of the disease types, and that not just 1, 2, or even 3 tumor types benefit, but it's clear that 4 or more tumor types clearly benefit with sufficient patients enrolled to each of those tumor types. So we are getting asked this question more and more as we run these clinical trials. What is sufficient for us to say it's tumor agnostic versus tumor specific? So to expand, the indications for tumor agnostic therapies, we really have to work together. And there are a lot of different stakeholders involved in this type of work. Of course, patients are at the center of all of this, but the clinicians need to work with the pharmaceutical companies, the diagnostic companies, the investigators who are running the clinical trials, the regulators who are making the decisions about, is this sufficient for us to give, grant an FDA approval and give the wider community access. to a therapy. And then, of course, the payers who depend, who pay for this therapy through insurance. Collaboration is really critical in order to bring up this conversation of, when are these types of therapies worthwhile to give in this way. So what can patients and advocates do? Patients can talk to their doctor about getting molecular testing to start. This is something that I think is becoming increasingly important. There is panel next generation sequencing, which is one of the types of tests I mentioned. It's basically a panel of tests of genes tested all at once, which is often the most efficient way to get DNA sequencing. And there are a lot of commercial vendors, Foundation Medicine, Caris, Tempus, that I could go on, but that you can send your tumor to have this genetic testing done. HER2 protein testing is a little bit different. You can see a HER2 amplification in the DNA, but there also can be HER2 protein that is overexpressed in the absence of an amplification. And that would be seen by looking under the microscope. So you would have to, a clinician would have to order that specific testing. Mismatch repair status is another one that can sometimes be seen on DNA or on protein. There's different ways of looking at it. And of course, clinicians and advocates can support clinical research in precision oncology, learn about it, which you're doing by just being here today, engaging with regulators to help regulators understand this evolving paradigm of oncology, participating in a clinical trial, or supporting a family member who participates in a clinical trial, and of course, fundraising for research. So in conclusion, there has been a shift away from histology-specific drug development to molecularly driven drug development. It may be helpful to get DNA or RNA sequencing with HER2 immunohistochemistry in advanced cancer patients to understand their treatment options. There are 9 tumor agnostic FDA approvals for 6 biomarkers, and I've listed them here. But as our armamentarium grows, our therapeutic armamentarium of different treatments, there are new tumor agnostic biomarkers that will emerge. Some new or previously undruggable targets are now becoming druggable with the technology that we are developing. Drugs with increased potency, so stronger drugs, more selective drugs with less side effects, and an improved therapeutic window, meaning they're stronger with less side effects. These are all things that we're working on. And as we get better drugs, we'll be able to target both new and old biomarkers in a better way. And then, of course, there are drugs with totally new mechanisms of action. I mean, an antibody drug conjugate, I talked a bit about the trastuzumab deruxtecan, but there's also a long list of new types of therapies being developed. And new types of therapies will allow us to target biomarkers that we have not previously been able to target. So I'd like to thank you for your time. This was a complex topic and something I'm really passionate about. And I encourage you to send in questions if you have any. Thank you.